Hello, my name is Anne Kennedy. I'm a professor of radiology and imaging sciences at the University of Utah and also an adjunct professor of obstetrics and gynecology. And today I'm going to give you my spin on skeletal dysplasias. This talk is being recorded in October, and that's why I gave it the name An Approach to Skeletal Dysplasias That Won't Rattle Your Bones for a Halloween theme, but its more politically correct title is Prenatal Diagnosis of Skeletal Dysplasias. And I brought this subject up because it's something that I'm actually rather scared of in my own clinical practice. When I was thinking about how to approach it in a way that wouldn't be intimidating, I decided to focus on the bone that we all look at all the time. We are not scared of the femur. We measure it on every study that we do. So think about the femur. Are there one or two? And you might think, really? But yes, you should check that two lower extremities are there and that the femurs are symmetrical in length. And then you need to look at the length of the femur. And when we talk about the length of the femur, what do we really mean by that? We mean whether it is appropriate for gestational age or not. So if the femur is the only thing we're thinking about, first thing you look at is how does it relate to the gestational age and how well do you know the gestational age of that fetus. Then you compare the femur length to the BPD to calculate a risk for trisomy 21. We do this with both the femur and the humerus, and it's important to realize that this is a mathematical calculation of the bone length in relation to the biparietal diameter, not just to the gestational age. And then if you do think your femur is not normal, look at the rest of the bones in that foot. Look at the tibia and fibula and the foot itself. If you have a single abnormality in a single extremity, you can think about limb reduction defects or amputation, perhaps for something like amniotic bands. Or in maternal diabetes, you can have a short femur, you can have caudal regression syndrome. There are specific entities that go along with that condition. If there's more than one bone involved, so you've just looked at one extremity, you've looked at the femur, and the tibia and fibula on that side seem to be small as well, then you really need to look at all of the long bones in that fetus. And we measure all of them diaphysis to diaphysis, just the same way as we do for the femur. You should be aware that curved bones can appear to have different lengths depending on the direction that you take the measurement in. Then you have to do the math. And I love radiology because it's all about the pictures, but every so often we do actually have to do the mathematical / sciencey stuff. And one of the things we do is we do a ratio comparing the femur length to the foot length. Now, femur length to foot length, stop a minute and think about that. If you look at your own femur length and your own foot length, you're going to go, how does that help me? But remember that fetuses become infants, and infants have very different proportionality of their legs to the rest of their torsos. And the femur to foot ratio is a useful measurement in a fetus with short bones, because if it's less than 1, it actually suggests there is a real skeletal dysplasia going on. And here is a picture of a cute little baby to show that there's the foot length, and roughly from bottom to knee is the femur length, and you can see that these are actually much more in proportion in an infant they would be in an adult. So what about the math thing? And everything that we measure standard deviations as well. So if you look at the length of the bone and how many standard deviations below what it should be for gestational age its measurement is, that gives you an idea of whether you're dealing with a skeletal dysplasia versus a sort of familial short stature, and if it is a skeletal dysplasia, how bad it may be. So very oftentimes, fetuses that have short, long bones, it's 2 to 3 standard deviations below the mean, and that can be one of the many, many, many named non-lethal skeletal dysplasias that are described. Maybe an anatomic variant, or it may be familial. For example, myself, I have a very large head. My mom likes to remind me of this every time she gets to talk about my delivery. And I'm also relatively short. So I have a large head and a short femur, but I'm considered normal. If you go on to fetuses where it's more than 4 standard deviations below the mean, you're definitely into skeletal dysplasia territory there, but probably not into the lethal ones. And the ones that are lethal are associated with very, very short long bones, often greater than 6 standard deviations below the mean. And the important thing to take home from the math issue is that the more standard deviations below the mean the long bones are, the worse the prognosis is for that particular fetus. And the earlier you see long bone shortening, the worse it is. I'm going to show you a case later where the long bone shortening only becomes apparent later in pregnancy. Also, there's a lot of information coming out now about femur length and growth restriction. And if you see short bones at a standard second trimester scan, you can bring that patient back and see what's happening, and are the bones getting progressively shorter, or are they staying about 2 to 3 standard deviations below the mean consistently. And progressive shortening can be a clue to achondroplasia. One of the things about this whole math thing is there's an awful lot of busy work involved, and my colleague Dr. Winter, who is a math physics major before he did his medical school training, wrote a program that makes it very easy to do all of this measurement and calculation, and the link is in this journal article. And basically all you have to do is enter your measurement into this program, and then it will calculate all the math for you with the number of standard deviations below the mean that all of the individual bones are. So we mentioned achondroplasia, and not only are we doing the math thing with this, we're getting out a protractor, which is something I bet many of you have not seen since your high school days. Achondroplasia is the one where you get progressive limb shortening as gestation progresses. So this is a graphic of femur length. This is a graphic of abdominal circumference, for example. And the fetus grows perfectly normally during pregnancy, except for the extremities, which start out a little bit short and become progressively shorter than the standard measurement as the pregnancy progresses. So if you're seeing this and you're seeing short femurs, you can look at the femur in a slightly different way. When we train, we're all very clear that you must measure your bones from here to here and not look at anything beyond the diaphysis. But in fact, if you look at this little angle here, it's called the proximal femoral diaphyseal metaphyseal angle. And you can see, you can measure that, and it's been demonstrated that in achondroplastic fetuses, this angle is increased. And in that study that was recently published, 5 of 6 affected fetuses had an angle greater than 130 degrees. So have that in mind, is if you see short bones and you're getting progressively shorter as you follow up the infant or the fetus, you can measure this angle, and if you see the increase in the femoral diaphyseal angle beyond these numbers, that's further information that you may be dealing with achondroplasia. Another thing in achondroplastic fetuses is that there is a persistent lumbar kyphosis, and this is a fetal spine turned to look like a sagittal X-ray. Here's the sagittal X-ray for comparison, and most fetuses will move and change their position, but you'll notice this persistent sort of curve to the lumbar spine. And here's a picture from the internet of a normal child and his achondroplastic sibling, and you can see how the spine is so much shorter along with the proximal limb shortening, which is quite marked. Here's an example of frontal bossing, which is another feature that you see in achondroplasia. You have a rounded protuberance of the frontal bone, and there's a characteristic appearance in the hand where the fingers are short, but they're equal in length, and there's a gap between the 3rd and 4th fingers. Now, I'm a Trekkie, have been for years, and Mr. Spock is certainly not achondroplastic, but he does a lovely example of that gap between the 3rd and 4th fingers, if that helps you to remember that sign. Achondroplasia is compatible with a perfectly normal life. There's normal intelligence, and I pulled this picture from a British newspaper to show this young lady who is actually an Olympic athlete and won a medal for freestyle swimming in the Beijing Olympics. The more important skeletal dysplasias to make a diagnosis of in terms of pregnancy management are those that are lethal. And there's really only 5 of those, as opposed to many, many, many named non-lethal skeletal dysplasias. So if we think about the lethal ones, thanatophoric, osteogenesis imperfecta type 2, and achondrogenesis are 100% lethal. Therefore, it's very important to be aware of those diagnoses and try to make a prenatal diagnosis so that you can discuss the pregnancy management with the parents. Short rib polydactyly group contains a number of entities, not all of which are lethal, but many are. So we quote about a 70% lethality risk for that one. And hypophosphatasia has several subtypes, but there is a perinatal lethal form. And if you are aware of specific sonographic features, you can come to a more specific diagnosis with either of these. That's important because there is a prenatal diagnosis osteogenesis panel, which is extremely broad and extremely expensive. So if you can narrow it down to say you really think this fetus has thanatophoric dysplasia, you can do more efficient testing. And again, once you have a confirmed diagnosis, the management plan for the pregnancy becomes extremely important, because we want to help families deal with the fact that they are going to have an infant who won't be going home with them, more likely than not. And you also want to avoid doing a cesarean delivery for a pregnancy that is not going to result in a live child in the long term. So what do we think about? We've mentioned that the femur is short, and it's really short, so we're worried about a bad skeletal dysplasia. Your next step is to look for fractures. And this is an example of a transverse image through the chest. This is the fetal spine, this is anteriorly, this is the cardiac apex. And notice how your ribs have a very angulated contour. This can only happen with fractures. This is a neonatal chest x-ray, and you can see that the ribs are extremely irregular. This is referred to as beading of the ribs, and you can see this on ultrasound as well, and that is because of many small fractures all lined up along the length of the rib. If you see fractures, there's only two things to think about. Here's another example. This is a femur, and far different than the usual nice straight femoral bone that we see. This is bent and irregular and angulated. And here's a neonatal radiograph, again showing a fracture and angulation of the femur, and also decreased mineralization. Another way to assess ossification, which is lack of ossification being a cause for fractures, is to look at the brain. And I know in my career as a radiologist, ultrasound resolution is now spectacularly different to what it was when I started. But never, ever do you see the near field of the brain this exquisitely on a transabdominal scan unless you have under-ossification of the skull vault. If it's under-ossified, you can compress the skull vault, and you can see that there's a flattening here, and this is the video clip showing pressure applied, and the actual skull vault is deformable with transducer pressure, which is not normal and implies decreased ossification. So we said two things to think about when you have fractures. That's osteogenesis imperfecta and achondrogenesis type 1A. That is particularly important because note that condition is autosomal recessive. Therefore, that couple, if they have another pregnancy, have a 1 in 4 recurrence risk, whereas osteogenesis imperfecta does not come with that type of risk. We said there are fractures in both. How are you going to differentiate between one or the other? Next thing you do is you look at the spine. And this is just a 15-week fetus, and this is a coronal image. So this is the spine, this is the contour of the outside of the ribs, and you can see that the ribs are very irregular in ossification. But although irregularly ossified, there is echogenic material within the spine, and that's the key observation. You have a spine here of an infant born with osteogenesis imperfecta with all of those rib fractures, but the spine is ossified. If you look at this fetus, you'll note that the spine is a column of black. It is entirely cartilaginous. There's no ossification here. And this fetus is actually at 22 weeks, unlike the last one, which was at 15 weeks only. There's a little bit of attempted ossification in the spinous processes, but not in the vertebral bodies. This is an abdominal x-ray. This was a fetal skeletal survey, and you can see the skull vault. This is something that we refer to in my own practice as the floating head sign, because the only part of the fetus that we could see any ossification in was in the skull. We could not identify vertebral bodies or long bones. Now look at those two cases side by side. Here's a coronal 15-week scan with definite ossification in the vertebral column. Here's a sagittal spine view with absolutely no ossification whatsoever in the vertebral bodies and just a little bit in the spinous processes. So that's how you differentiate between osteogenesis imperfecta and achondrogenesis. So we had 5, we're now down to 3 to think about. The next one we're going to talk about is thanatophoric dysplasia. And the way to think about that, again, is to keep looking at that spine. So here's a neonatal chest x-ray and a neonatal spine on either side of a coronal fetal ultrasound. This is the fetal abdomen here from side to side. And you can see that the chest is tiny, and the heart actually takes up the chest from side wall to side wall. Looking at your x-ray again, you have that small chest appearance. But look at these vertebral bodies. There's only a little bit of calcified vertebral body and a whole lot of intervertebral disc space. Same on the lateral. The vertebral body is very flat, the intervertebral disc space is large, and this is described as platyspondyle, meaning flattened vertebral bodies. So what does that look like on ultrasound? The ossified vertebral body is echogenic, the intervertebral disc is hypoechoic. So I've turned this ultrasound around to mirror the appearance in this radiograph, and you can see there's your flattened vertebral body, just as you see here, and your increased intervertebral disc space, just as you see here on the radiograph. Here's another example. There's a sagittal of the spine. Here's a sagittal of a normal spine. The vertebral body is quite flat. The intervertebral disc space is increased. Vertebral body much bigger and actually less distinct at its margins than the intervertebral disc space in the normal case. Here's a paper from quite some time ago, actually 1990, published by Dr. Philly's group. And they described a mathematical way of evaluating platyspondyle, and they said to measure the vertebral interspace and the vertebral body height and create a ratio. The ratio is the height of the body over the height of the body plus the interspace, and they have lots of nice data in here. Here's an example of how we look at that. Here's a sagittal image of the spine in an abnormal case superimposed on a normal case. Now you look at your vertebral body, then you look at your interspace size here and here, and you can do the math and measure the ratio, but actually you can also do what I call the eyeball scan and just look at this, and you can see here that the intervertebral space is much bigger than the vertebral body height, and that is clearly abnormal, and that is what leads you to making a diagnosis of platyspondyle, which then takes you to consider thanatophoric dysplasia. TD is associated with some other findings. TD2 is famously associated with the Kleeblatt-Schädel skull deformity, which is also known as a cloverleaf. And in my attempt to find cloverleaf examples, I found cloverleaf rolls on the internet. And you can see, again, very prominent frontal appearance with an upturned nasal tip. And then here is your cloverleaf appearance right here, due to the craniosynostosis associated with this diagnosis. Here's a 3D reconstruction. Again, you can show the marked bulging of the frontal bones, and you could do a 3D surface reconstruction and an axial image if you wanted to bring out that shamrock or cloverleaf appearance. TD1 is associated with a very characteristic appearance of the femur. It is very shortened and curved. Here's a 2D, here's a 3D, and here's a radiograph of this typical appearance, which was described as the telephone receiver femur. Now, unfortunately, for the generation of sonographers and medical students coming up, a telephone receiver looks nothing like that. It's now a smartphone and is shortly going to be just a piece of tape you stick on your forearm. But it was originally described to illustrate the fact that it was short with curved ends, just as you would pick up an old-fashioned telephone. All right, we mentioned 2 of those guys that went away. We mentioned 3 of those guys that went away. So now we're left with the short rib polydactyly group and hypophosphatasia. And the short rib polydactyly group, like I say, is not uniformly lethal, but there is a characteristic appearance. If the ribs are short, then your chest is going to be small. And anytime you see a fetus that you think has cardiomegaly, you need to ask yourself the question, is the heart big? Or is the chest small? And there's normative data out there for chest circumference and chest height for gestational age. But also, if you do a coronal image through your fetus, if the chest appears pinched in relation to the abdomen, that is described as a bell-shaped thorax. And this is a radiograph of this child when after delivery, and you can see the chest is very straight-sided and then flares at the bottom. Ossification is normal, there aren't any fractures, but the chest is small and the ribs are short. They don't curve around in the normal way. This again is from the Daily Mail in the UK, and this is one of the cases of a short rib polydactyly syndrome infant that did not die, but this baby is facing a lot of surgeries in his lifetime to try and widen his thoracic cavity so that he can oxygenate appropriately. All right, we got rid of those guys, we got rid of those guys. What are we left with? Hypophosphatasia. And that is, as I say, there are multiple subtypes of that condition, but there is a perinatal lethal form. The key characteristic of hypophosphatasia is that the bones are severely demineralized. So it's not like in the osteogenesis imperfecta where there was almost no ossification of the skull vault so that it was easily deformable, and it's not typically associated with dramatic fractures like osteogenesis imperfecta is. It's more what we call moth-eaten, ratty-appearing bones. They just are not normally mineralized, so you can see through them better than you expect to, but they still do show some echogenicity, indicating some ossification and mineralization. Here's a chest radiograph of an infant recently born with that diagnosis, and you can see how incredibly thin and gracile the ribs are. The vertebral bodies are ossified, but not heavily calcified for an almost term infant, and the scapulae are small and moth-eaten. The humeral head and neck is very poorly mineralized. Here's an example of that moth-eaten appearance of the bones. You can see that it's not a nice white, sharp, linear interface with shadowing from it. And there is some angulation and distortion of the bones. But in comparison to an osteogenesis imperfecta, for example, there will not be that ribbed, beaded appearance and the marked intensity of fractures in every bone. And here's an example of the angulation of the femur and tib fib in a radiograph of this case when the infant was born. All right, we mentioned the math, and I keep going back to that. So micromelia really is tiny limbs. The smaller the limbs you have, the more likely you are to have a severe skeletal dysplasia. And remember, we said if the standard deviations are greater than 6 below the mean, the final diagnosis may not be apparent, but the prognosis is always bad. There are other things that we measure. We mentioned the foot length because you can do the foot-femur ratio to identify if you have a skeletal dysplasia. And we always measure the abdominal circumference as part of our normal biometry, and we can measure the chest circumference to confirm the visual impression that the chest is small. A foot-femur ratio less than 1 suggests a skeletal dysplasia. A femur to abdominal circumference less than 1.6 suggests that the dysplasia you're looking at is one of the lethal varieties. And a chest to abdomen circumference ratio of less than 0.8 also suggests lethality. What's the overall approach to a skeletal dysplasia? First of all, do you have one? Are you dealing with just a familial short stature? You use your standard deviations for that, and you also use your foot to femur ratio. If the bones are short, which ones? Are they all short, or is it a rhizomelic bone shortening alone? Because that changes the differential. When was the bone shortening seen? The earlier you see short and long bones, the more likely you are to be dealing with a bad versus lethal skeletal dysplasia. What size is the chest? The small chest is the thing that makes these children unable to breathe and to oxygenate. So the small chest size is again associated with lethal conditions. Look at your head shape and ossification. If you see that typical cloverleaf shaped skull, that goes along with thanatophoric dysplasia. If the mineralization is very poor, go back and look again for fractures, and you're probably going to go down the osteogenesis imperfecta differential. If the spine is completely lacking in ossification, that's achondrogenesis. And always, in any case of any fetus with abnormalities, look at the hands and feet, because you may get clues to a specific diagnosis, such as that characteristic 3-4 finger gap that you see in achondroplasia. The lethal skeletal dysplasias are early in onset. The chest is small. There can be fractures or marked bowing, cloverleaf associated with thanatophoric dysplasia type 2, and the presence of hydrops is always bad. Remember your measurements to suggest lethality. The bad guys involve multiple bones, and it's really important to try to arrive at a diagnosis of lethal versus non-lethal so that you can have a discussion about delivery planning with the parents. It's also very important to try and establish a specific diagnosis in all cases. So when you're having that discussion about the delivery plan, you also need to broach the subject of how you're going to make a specific diagnosis, whether it be by a full formal autopsy or whether it be something like just, for example, a bone biopsy, depending on the family's wishes. The importance of the specific diagnosis is that in autosomal recessive conditions, there's a recurrence risk of 1 in 4 in future pregnancies, which may change families' reproductive plans. Thank you.